I'm just flattered. Well, I bring you greetings from Mother Africa. I bring you warm regards from Nigeria. I bring you the warmest love from people living with HIV/AIDS, especially those who are suffering from opportunistic infections. They are the reason why I'm here today. I truly have not actually been so proud an African in a foreign land than I am today. When you look back, you see an epitome of African. You know, the lady behind, when I saw her this morning, I was so proud. She looks truly African. Okay? You know, throughout this conference, we've been taught the molecular basis of HIV in some parts. And the social scientists have been trying to balance the equation. I'm so happy today. And the conference actually has educated me more than I ever could have imagined. The foremost person you know in the US here, who happened to be a social fighter, Martin Luther King Jr., once said something that a government that is only interested about the infrastructure and the development of the citizens, and yet not interested about the economic and social conditions that cripples them, is a moribund government. So when you extrapolate this to medicine, when we are only interested about the clinical condition of the patients and not interested about their social conditions, I think we are moribund. And that's why in some years past, good medicine practice or good medical practice involves the fact that you must see patients holistically. So, this having been said, I would like to introduce the topic, pulmonary cryptococcosis, in a known TB/HIV co-infected client attending care in FMC Owerri, a case report. If you look at your manuscript or what, you discover that the topics are not the same. So this is what the topic should actually read. So, as a means of introduction, permit me to be kind of a little bit technical, but if you have any questions, you can ask me at the end of the stuff. Cryptococcosis is a clinical condition caused by a cryptococcus organism, and this is an encapsulated fungus. Cryptococcus neoformans is the main organism in the immunocompromised, though other forms, like the C. gardii, may rarely cause infection in this group. In HIV-positive patients, it is an AIDS-defining illness. It is currently the second commonest opportunistic infection after tuberculosis in Southeastern Asia. Its clinical manifestation in HIV/AIDS may range from pulmonary through meningitis to skin affection. In such a situation, you could be allowed to use the term disseminated crypt. The commonest presentation in HIV individual is a CNS presentation. Mortality may be as much as more than 50% if left untreated. Pulmonary cryptococcosis has similar clinical presentation with pulmonary TB, and co-infection of the two are rarely reported among HIV/AIDS patients. Definitive diagnosis requires positive culture of the organism with seborrhoid dextrose agar, microscopy showing a halo after staining with your Indian ink, and compatible clinical features. In areas like in the US and other developed countries, you could also do your PCR for confirmation. So, I want to present the patient. Here comes Mrs. C.A.N., who was a 42-year-old Nigerian homemaker. She was a known HIV-positive client attending care in our clinic. She was on ART, then her CD4 count at the time she reported was 96 cells per mm cube or per microliters. While on ART, she developed tuberculosis and has been on continuation phase of treatment with good progress made. Her clinical symptoms was noted to have deteriorated 2 months into the continuation phase and was marked with new onset progressive cough of 2 months duration, progressive weight loss of 1 month duration, chest pain, 3 weeks, recurrent low-grade fever, and loss of appetite. Cough was productive of mucoid sputum, no hemoptysis. Hemoptysis is blood in the sputum. Sputum was not copious and not position dependent. Probably for the clinicians, you discover I'm trying to rule out 1 or 2 things here. History of SOB on moderate exertion. She had no history of night sweat, leg or facial swelling. She had no known contact with anyone with chronic cough and resides in a 2-bedroom apartment with her husband and 3 children. She neither smoked nor used biomass fuels as a source of energy for cooking. You know, in Nigeria, in the rural areas, you see people still using firewood as a source of energy. And if you continue to use that, maybe from your childhood up to age of about 50, you're predisposed to what we call COPD. So why in the Western world, like here, cigarette smoking is the leading cause. Down there is our firewood. She had no known history of COPD, I said. She was on cotrimazole, 960 milligram daily. Sorry, that is not IPT, a CPT. On general examination, she was ambulant, dyspneic, not pale, febrile with about 7.8 degrees centigrade. She wasn't dehydrated. She was not cyanosed. She had no peripheral edema and no lymph node enlargement. These all had medical connotations. Respiratory examination showed normal symmetrical chest wall, a respiratory rate of about 22 cycles per minute, trachea central, equal chest excursion, resonant percussion node, and vesicular breath sound was normal. Vesicular breath sound, sorry. Cardiovascular, CNS, and skin examinations were unremarkable. A presumptive diagnosis of multi-drug resistant tuberculosis on background HIV/AIDS was entertained with the following differentials: pulmonary fungal infection, pulmonary malignancies, and pulmonary nocardiasis. The following investigations were requested and the results were obtained: Zionation staining of sputum, times 3, they were all negative. And you know, because of a lot of issues for TB, zero Nielsen staining is WHO standard for us in Africa. You people here may do one or other things, but as we progress, we'll see. Gram staining of the sputum was also negative. Sputum culture and sensitivity, no growth on nutrient and blood agar after 24 hours of incubation at 7 degrees centigrade. The mycobacterial culture was not done. We don't have the facility. Gene expert of sputum was requested. It was positive for tuberculosis, but no resistance to rifampicin and Yersinia azae was recorded. High resolution CT was requested but was not done because of financial issues. Chest radiograph shows reticulonodular shadows with patchy opacities. Then culture on SDA impregnated with cyclohexidine to prevent other bacterial infections, other bacterial growth. Then that yielded light, yellow mucoid, and confessed growth after about 24 hours at the same period of that 7 degrees centigrade. 2 different sputum specimens 4 hours apart were tested to prevent bias. Cultured organism demonstrated characteristic halo on Indian's ink stain upon microscopy. So presumptively and definitively, C. neoformans was actually reported. Lumbar puncture was done with negative, with CSF, and that was negative for culture and Indian ink stain. This is very necessary so that you can rule out CNS infection. A working diagnosis of pulmonary crypt on the background HIV-TB co-infection was made. Patient was placed on TAPS, fluconazole, 400 milligram 12 hourly, to continue her ART, lamivudine, zidovudine, and efavirenz, and other previous medication. Then to improve on her nutrition, because during the conference, my experience in the US, Hampton time, you have coffee break, tea break, this meal and that meal, and I was discussing with somebody, I said, these people eat a lot. That is not so globally, so you don't need to take that for granted. The patient was encouraged to do the other requested investigations. She was given 4 weeks appointment for further review. Then patient had improved significantly after 4 weeks and was lost to follow up afterwards. What were the challenges we had on this patient, and what lessons can we get from that? As clinicians, you must have a high index of suspicion, especially in a very poor resource setting, where you don't have the arrays of the investigative tools for you to rule out 1 or 2 things. Here you depend so much more on your clinical acumen. There's actually a delay in making a definitive diagnosis. Hence, the drug was not just started immediately. There was also a possibility of mistreatment, maybe treating the wrong condition. And also, the patient has lack of trust in the healthcare system. You see, it's a place where people, when other social scientists are talking, because some people, due to some cultural belief and myths, people don't believe that the natural drugs are working. So they believe they better go to the prayer house, okay, or stay in their house, or do 1 or 2 other things to better their condition. So a lot of information and education is actually needed. That's why I'm so much impressed by the people that actually gave us lectures on social issues. So the shop for other alternative to treatment, prayer house syndrome, patent medicine dealers, herbal remedies. Here comes a place people could easily walk into the pharmacy and will tell the pharmacist, could you kindly give me 2 capsules or 3 tablets of antibiotics? It's crazy, And the pharmacist will kindly dispense, all for money. So issue of resistance is geometrically increased. It's a place, if I'm a doctor, I will tell somebody I'm a nurse, but that's not why we're here. The poverty, poor political will to equip the healthcare system and train staff and implement universal national health insurance. You will enjoy that for free here. National health insurance scheme is for the federal workers, which I enjoy with my lovely wife here and my kids. But it's not yet universal. Rather, people will be interested in buying Bugatti Jeeps or Bugatti cars at the expense of other Africans who cannot afford a meal. That's crazy. Sorry, I will take some of your time. So, immunocompromised individuals are seen in all these conditions are known to be a risk factor for crypt and TB. In the United States, about 7 to 15% of patients with AIDS develop crypt infection. However, in 1993, the CDC reported that 6% of 274,150 patients with AIDS developed crypt disease. Patients with AIDS-associated crypt infections account for 80 to 90% of all patients with crypt. In sub-Saharan Africa, 15 to 30% of all patients with AIDS develop crypt diseases. I did a study in my center, which I presented here 2 years ago, and we got a prevalence of about 10%. That is quite high. The male to female ratio for the condition is essentially equal, according to most researchers, though our patient also was a female. I don't know why female. Pulmonary crypts include clinical entities ranging from asymptomatic to severe acute respiratory distress syndrome. In most cases, the infection is believed to result from reactivation of a dormant infection, with the infecting propagules being acquired before the diagnosis of the condition. However, lung disease can also follow recent inhalation of infectious propagules and produce acute infection. Our patient was a known HIV-TB co-infected patient whose CD4 was about 98 cells. Our clinical features were consistent with many pulmonary opportunistic infections and malignancies, including tuberculosis, histoplasmosis, which is seen more in the South American regions, nocardiosis, and pulmonary lymphoma. Epidemiological considerations are key to diagnosis because you have regional specific conditions, but must be augmented with clinical history, physical examination findings, and relevant investigations. In our case, because of the history of chronic cough, chest pain, loss of weight, anorexia, in a known immunocompromised patient living in an area with high prevalence of tuberculosis, we still felt that she had tuberculosis, most likely an MDR. Further evaluation based on culture and Indian ink of the grown organism helped us to confirm the diagnosis of crypt. You have to work with what you have, which is standardized. The patient's CSF staining and culture were negative. This assisted us to rule out possibilities of CNS infection, which would have given an idea of dissemination. Most of the investigations done were offered free by the heart-to-heart center. The woman could not afford most of the investigation. So the heart-to-heart center is a support center we use in our country, in my facility, initially fully sponsored by the US government, but the sponsorship has drastically gone down. So we are trying to, augment, though little support still comes from the US government, especially the USAID and the PEPFAR. The negative zonation staining seen in the sputum does not rule out the possibilities of TB co-infection, because studies have shown that about 15 to 20% of people who have HIV actually will be negative. Reason, if you are having HIV, that means that you're immunosuppressed, so those natural cells that fight for you, like the macrophages, are reduced. So the number you will see in the sputum is reduced. So for your ZN staining, you expect to see out of 100, between 15 to 20. So it's just known. However, the positive gene expert test confirmed the presence of MTB without presence of rifampicin-resistant strain. As an aside, night sweat is more common in TB and usually are not seen in pulmonary cryptococcosis. Hemoptysis is also a common symptom in TB, while it is rare in crypt. Negative gram and zero stain of the sputum rules out pulmonary nocardiasis. Also, the patient had been on 960 milligram of cotrimazole, which is also cidal to nocardia species. So the treatment of pulmonary cryptococcosis depends on the clinical presentation and the immune status of the patient. So for people who are asymptomatic, you may not treat them. If you're asymptomatic and you are immunocompetent, you may not need treatment. But if you're symptomatic, you may likely need treatment. If you're immunocompromised, you have to be treated. Okay? The following guidelines, according to the Infectious Disease Society of America, are useful for pulmonary cryptococcosis in the immunocompromised. So because a lot of work are ongoing here, we base most of our treatments on the guidelines developed by people who are actually thinking and working. It's not that we are not thinking, we are seriously thinking, but we are limited by facilities. In the immunosuppressed, patients with pulmonary crypt and meningitis should be ruled out by lumbar puncture anywhere in the world. That is the standard. The presence of CNS disease alters the dose and duration of induction therapy and the need for intracranial monitoring. Pneumonia associated with CNS or documented dissemination and severe pneumonia is treated like the CNS disease. So these are much of the guideline. So essentially, drugs like the amphotericin B is the drug of choice for crypt. Fluconazole are still sensitive to crypt, but we do not have amphotericin B. It's not that it's not available, but the program we are running, Heart-to-Heart Center, we don't have the amphotericin B, but if we had purchased, looked for that, we would have seen. Okay, but we considered in the management of patients, you must consider the patient's ability to get one or two drugs, because you may have the best drug for your patient, but the patient cannot afford that. So you've done nothing. So in our index case, there were no features suggestive of CNS affectation, hence our placement on TAPS fluconazole. She commenced the therapy, improved, but was lost to follow up after 2 months of treatment, after she had done perfectly well. So mortality rate of pulmonary crypts in AIDS patients has been slim, even has been very poor. Some has put the figure to 28%, even when treated with non-amphotericin-based regimen. Cure is often impossible, and patient requires lifelong suppressive therapy. So until our people living with HIV/AIDS are free and treated of their opportunistic infections, we will not truly be free. On this note, I want to thank my wife for allowing me to come to the US with me, and for supporting me all the while. Without her support, I don't think I would have been spending some of our salary on this work. She has to deal with me. Sometimes I could tell her, hang on, let's not make this or that. So thank you very much.